at the University of British Columbia. Dr. Drysdale has had an interest for over 30 years in near-death experiences and has taught about NDEs to patients, grieving families, physicians, and other healthcare providers. Would you please help me welcome Dr. ELAINE Drysdale? Thank you. You are on over here? Yes, you are.
Okay, nice. Okay, I think we're cooking now. Well, again, I'm really delighted to be here. And this afternoon, I want to talk primarily about near-death experiences and how stories of near-death experiences can be healing in so many different dimensions, in areas of care, in different clinics, inpatient work, emergency, outpatient work with friends and family. Why aren't we telling these stories more often? So this is a patient of mine. She's a high-powered professional, very high-powered. She was given a life-threatening diagnosis that required extensive medical treatment. The patient stated, "You know, the spiritual and emotional aspects have been huge, huge, huge in my illness. Everything was affected, and I was absolutely overwhelmed and constantly preoccupied with the fear of dying." So in helping to treat her and help her with her anxiety, are the spiritual aspects of her fear of dying relevant? Of course they are. They are central. How would we help her? Think about that for a moment. In terms of standard medical care, what would we say to get her through it? Some people would send her to mindfulness meditation, but beyond that, how would we help her? So some of this I've presented already in one form or another this morning with you, and thank you for being so patient with me this morning when I had some logistical issues here. So now I would like to talk about the more mystical spiritual experiences. How do we ask about them? How do we deal with them? Such things as near-death experiences, out-of-body experiences, shared death experiences, and other spiritually transformative experiences. Well, when I talked to you this morning about assessment in spiritual care, it was really about coping with spiritual issues, wasn't it? It was basically coming out of the type of material that we heard yesterday with Dr. Koenig, and issues of faith and spirituality, one's beliefs, and how that would impact on medical care. But it doesn't really help us with accessing the patient's more private spiritual experience. And what has been the most helpful thing came from Dr. Lauren Bell. She's an intensivist. She works in ICU, and she's written a book, Near Death in the ICU. And she's a wonderful physician and person. And she said the bottom line is, just ask, did you experience anything unusual? Did anything unusual happen to you when you had that code or when you were in hospital? And that has made all the difference in patients telling me things. But I say, before you answer that, and this is what I say to the patient, did anything unusual happen when you were in the hospital? But before you answer that, by a few things. Because I'm a psychiatrist. What patient is going to tell me, well, yes, I had a vision? You know, nobody is going to do that unless I set the stage. So I say, you know, I know that people can hear or see things for many reasons. Sometimes it's because the brain is ill, and sometimes for truly spiritual reasons. So I'm not going to assume that everything is pathological, just so that you know that. And I certainly don't think everything is a sign of illness. Now, saying that also makes a huge difference, because then patients, friends, people will relax and know that I'm not going to be critical or judgmental. Of course, I might not say that if they are really psychotic and in the emergency room. I use some judgment over it, but patient, this is a good thing to say. I did this with a woman who'd had a transplant. I'd seen her once, and this was the second time I saw her. I mentioned this, asked her this, and she said, well, now that you ask me like that, I'm going to tell you, the night before my transplant, I saw an angel. She was 10 feet high. I couldn't see her face. She's drawn a face here. She said, I couldn't see her face. It was just this incredible light coming from her wings and from her being. The wings were incredible, but she said I could see every detail of the feathers all the way down the wings. And after she was discharged from hospital, she went home and drew this. And this is the angel that she saw. So if I'd done my usual standard kind of approach, have you seen anything unusual or heard anything unusual? I wouldn't have gotten anywhere. So this is the way to ask. Now, I believe that near-death experiences are important stories for teaching patients, for teaching people about how to be more confident about dying, about the life process. First of all, I think that near-death experiences it's important that healthcare professionals understand the phenomena because we can validate it when a patient's had a near-death experience, and that's so important. We don't want their experience to be minimized or pathologized. But then, when you think about it, if you can get staff on board to acknowledge the content of the NDE, or to, first of all, acknowledge that it's a legitimate experience, it's a valid experience, then people start to think, oh, what is that content? Well, maybe there is something to this. So I think that's the bridge to the spiritual, that I think it's the way to go in healthcare work. If we want physicians, other healthcare workers to consider spiritual possibilities and to consider non-local mind, and this morning, that I think using the material of near-death experience as the bridge is really a wonderful way to go. Now, near-death experiences are very common. They occur in 5% of the people, of the population. And that's, you might find surprising. Why don't we hear about them more often? And it's because people keep them very private. If you start asking around, you'll be amazed how many of your friends, even relatives, have had them. In fact, I've had several very close friends who've had the experiences. And I was telling a family member about this video that he might like to watch about near-death experiences. And he said, oh, I don't need to watch that. I've already had one of my own. I said, you have? I mean, this is my own family, and he knew I was interested in this. And I said, well, you never mentioned that. And he said, well, it's kind of a private thing. I think he thought that, that as I was a psychiatrist, I might be judgmental of his experience. But when he'd had surgery, he watched the whole lung surgery from a different part of the room. He watched everything. So patients often are very reticent to talk about something that's been so profound to them. So it is quite amazing that 5% of the population has had this kind of experience. But the good news is that for the other 95% of the population, we don't need to have a near-death experience. We can learn from the stories of people who have had them. And that's where I think health care professionals, I think it's time to speak out. It is for myself. I've certainly felt a sense a few years ago, okay, it's time not to be flying under the radar with this, but to come forward and to acknowledge that as a physician, psychiatrist, that I believe that these experiences are valid, that they are different from a delirium, that biological theories don't fully explain near-death experiences. And I wanted to make a public statement that I endorse the spiritual possibilities of it. I think it's important to understand who might not even realize they've had a near-death experience, and we can help in that way too if we ourselves have better knowledge. So we can use this knowledge in many ways therapeutically, in many settings. So I want to talk briefly about the history of near-death experiences. I think many of you might be familiar with Dr. George Ritchie, who's a psychiatrist. I think he spoke at Congress here before. But Dr. Ritchie had a powerful experience, and he wrote about it in his book. I've got a picture of it later. But Dr. Raymond Moody, who wrote the book Life After Life, was inspired by Dr. Ritchie's story. Raymond Moody had heard George Ritchie speak and was quite impressed by this. And then Raymond Moody was in medical school and heard a second person with a similar story, not quite as evolved or elaborated. And so Dr. Moody said, there can't be just two people in the world that have had these experiences. There must be more. So that is what motivated Dr. Moody to look at, talk to people to see who had experienced such phenomena. And he reviewed cases of 150 people. And they fell into three groups, these people who had these experiences. Some were ones who'd had cardiac arrests and were resuscitated. Some were people who'd come very close to death in illness or injury, and some were experiences of people that, as they died, that were reported by the surviving relatives. So he wrote a book in 1975 called Life After Life, outlining the near-death experience. And it became a bestseller, and then it was featured in the Reader's Digest Book of the Month Club, or they had a synopsis of a book, and that changed everything. This was before Oprah, and it became very well-known suddenly with that publication, and suddenly it hit the movie scene. There was a movie that featured a symbolic version of a person undergoing a near-death experience, and that was about a year later. And then it became increasingly a theme in movies, and it resulted in a changed worldview of dying. So what was it that Dr. Moody outlined? He said, well, there are about 9 elements. Actually, since then, people have said there are about 15 frequent elements. But I like the way that Dr. Moody had outlined it, so I'm going to go over that quickly. He said there's a sense of great peace suddenly and an absence of pain, and then an out-of-body experience where people sense that they're floating above often, and they watch events below them. And they can often describe things from the vantage point of being higher up. They can describe the tops of shelves, the tops of equipment. They can report conversations down hallways. Then there's an experience of being drawn through a tunnel of darkness at a high speed until they reach a beam of radiant light at the end, or a sense of light. And some people do not report the tunnel, but they rise suddenly into outer space. And Carl Jung had that kind of experience where he floated on up and saw the Himalayas, and then he saw the Earth bathed in a beautiful blue glow. And this was before Google Earth or satellite pictures or even the astronauts' pictures. Other people have had that kind of experience as well. William Peters, who's done some work on shared death experiences, also had a near-death experience where he floated up and saw the ski slope where he'd been, and then the parking lot, and then the outline of California. Then people often report seeing other people who are deceased, friends or relatives who greet them, and they seem to be lit up. And sometimes they will see people that they didn't even know had died. One of the most interesting stories I heard of was one from the 1880s, was of a little boy who was delirious, and he he subsequently had a near-death experience, and he came back and said, after he recovered, he said, "Oh, Cousin Rachel looks so beautiful as an angel." And they said, "Oh no, that you were really delirious. Cousin Rachel is fine and well in Ohio." And but sure enough, the telegram arrived right after that Cousin Rachel had been killed in an accident. And this was in the 1880s, and that was a powerful story for me to read. So nobody knew that she had died in that family until he came back and reported it. And it was so reassuring to Cousin Rachel's parents as well. And often people are then met by a being of light that they perceive to be Jesus or God or a spiritual being. Then they have a life review, which is often a holographic kind of review where they see everything at once. They watch their life unfold, but they also feel and see the effects on other people of their actions. So, and the dying person may have a realization that acts of love, even though simple, are of the greatest value in one's life on earth. That's a powerful and repetitive message from near-death experience literature. And most people don't want to return, but they do because they either have to or they might be told feel that they have to help loved ones. And there are other elements that can occur that can be associated with these experiences, such as very intense emotions, heightened perceptions, perceiving a spiritual realm, often beautiful landscapes with vivid colors, or the city of Jerusalem, crystal, has been reported. There's often a life knowledge of the nature of the universe, or a sense of oneness, a sense of having knowledge of the future, messages regarding one's own life purpose. Some people only have one or two elements, some people have many. So after Raymond Moody reported this, then there was a lot of research by other people. A psychologist, Dr. Ken Ring, did work on people who were blind. Dr. Bruce Grayson, psychiatrist, was very involved. Then Dr. Melvin Morse reported on children's experiences. Dr. Jeffrey Long is a radiation oncologist who has kept a register of people who've had near-death experiences. I think there's something like 1,800 or a huge number have been reported to him. Dr. Pim van Lommel, who I understood has spoken here before, and I believe his statistics are that about 18% of people with cardiac arrests have had near-death experiences. Dr. Eben Alexander has made the field more widely known. Harvard, who wrote Proof of Heaven. There is an association, the International Association of Near-Death Studies, IANS, which people should look up and consider attending one of their conferences as well. So I'm going to skip over the definition of IANS due to time, but the main point is that it is a transcendent experience, it's a profound experience, and just being close to death is not a near-death experience. Sometimes I'll say, I'm death experiences. I had one of those, I got really sick and then I got better, but they didn't have any transcendent experience. So Melvin Morse's book reported similarities for children, and there have been similarities for other cultures as well. I thought it was interesting that he described a 10-month-old who crawled up the tunnel, and one child identified the child as the being of light as Santa Claus, another one as Elvis Presley, and I thought that was so funny, like a tabloid, but in fact, Elvis Presley, I think, had a very loving manner with people, and I think maybe that child had seen that loving sense, and so recognized that sense of love. So what are the biological theories of NDEs? And I want to talk about this because so often people are told, you were just delirious, and their experience is minimized. And so knowledge is power. I want to empower people so that if they are told that, they can say, no, it wasn't delirium. So what are some of the other possibilities? People are told they were psychotic or hypoxic or it was a temporal lobe seizure, or DMT release in the brain. I want to start with delirium. What constitutes delirium? Well, and I want to show you how different it is really from a near-death experience. So delirium is a disturbance in attention and awareness. And it tends to fluctuate. And it's what happens when people are septic or medication side effects, often morphine side effects. And so their thinking becomes disordered. And they may have hallucinations, especially visual hallucinations of small little flies. And they can be confused with thought processes that are often fragmented. They lack consistency and coherency. They're very muddled, although sometimes they may be adamant, but confused. And the recall is very fragmented. It's fragmented because it was never fully processed in the first place, so it can't be retrieved later. And there's often evidence in the medical history that there was a factor involved, such as hypoxia or sepsis or substance or medication side effect. Additional symptoms of delirium, often there's a psychomotor behavioral disturbance, that people are more active. Often the sleep-wake cycle is reversed, so they're awake all day and awake all night and sleeping during the day. Often they're very labile, with rapidly fluctuating mood states, anxious and irritated. They may be hypoactive, with very slowed down, and paucity of thought processes. That could be due to even things like low sodium level. Or they may be hyperactive and very agitated, like what you see in the movies as a delirium. They say, oh, the patient's delirious, and the patient would be all shuddering. And that's what you see, sometimes a tremor and an agitation with alcohol withdrawal and some med side effects. But that's the hyperactive form of delirium. So how does it differ from a near-death experience? Well, in delirium, there's partial awareness, partial ability to interact. Whereas a near-death experience, they're either unconscious, they're usually unresponsive totally. In delirium, symptoms fluctuate over time and in intensity. Near-death experience, it's all or nothing. Either you look dead or you're alive. Externally, you may look like nothing's happening. Internally, the experiencer is fully present, unlike in a delirium. And the experiencer, I'll put that slide back on for you. The experiencer, where was I? Fully aware and can validate those events later. Thought processes of a near-death experiencer, they're coherent in describing the event. It may sound fantastically imaginative to others, but it holds together in a very congruent way. Whereas in a delirium, people are muddled and their thinking shifts. They might be suspicious of one person 1 minute, and a few minutes later are suspicious of something else. Or I can't trust that nurse. So it can change. And in delirium, there are false ideas and misinterpretations of identities. One patient said to me, oh, I know you. We had that bank heist together. And so there's a lot of confusion and often distressing paranoid thoughts and misinterpretations. But the content is rarely inspirational. In fact, I've never heard a delirium that was inspirational in 30 years. To a patient. Patient often feels misunderstood, and they don't really feel during a delirious state usually. Whereas in a near-death experience, the content is very reassuring, hopeful, inspirational, and people feel loved and valued. Delirium the symptoms are explained by the illness affecting the functioning of the brain. Whereas a near-death experience, we can't explain how illness created that experience. I mean, someone who's looking comatose and yet they're having this very rich experience. We can't explain it. I'm going to just move along here in the sake of time. Emotional reactivity is part of delirium, but in a near-death experience, there's no emotions, there are no switching so much of emotions during the event, but then afterwards there's usually a sense of awe or humility, gratitude. Now, Dr. Bruce Grayson's a psychiatrist, and he's talked about the differences between mental illness, such as psychotic episodes, and near-death experiences. And in bringing this to the discussion of delirium, I've already talked about context and content. Memory for the event, delirium, it's always hazy. People don't really recall the full thing, usually. Now and then they do, but they're usually surprised to learn of some of their comments and behaviors. It's minimally processed. Whereas a near-death experience, there is extreme recall for details, and the memories do not fade over time, or very little. In the after effects, delirium, patients usually say, "What a nightmare." Doesn't have an impact on their sense of purpose and meaning, whereas in a near-death experience, it is transformational with a greater desire to express love to others, to be more philosophical, and to be less fearful about dying. Sometimes there can be double presentations. You can have both. And I think Dr. Eben Alexander's situation was one like that, because he talks about seeing the red sludge, and it was like primordial ooze. And I wondered if that wasn't inward, his brain shutting down, or he was aware of the pus in his brain, or his eyesight was shutting down, or maybe that was part of the transcendent part of the experience. Then he had a transformative near-death experience, and then he had a delirious experience when he was in the ICU. And I'm talking about this right now because I heard him speak in talk, and the woman in front of me said, "Oh, my dad, this is going to be so helpful for my dad because he's dying and afraid of dying. But I don't know what I'm going to tell him about the part where you come back to the ICU and you're really crazy at the end of it." And I said, "Oh, no, wait a minute. That was something separate. That was an add-on." So I've actually discussed that too with Dr. Alexander since then. But delirium can fluctuate, and especially when people are dying, there can be spiritual experiences mixed in. I had my companion a few years ago. He passed away in the ICU from complications of chemo. He developed pulmonary fibrosis, and so went downhill in the ICU over a period of days. But the day before he died, he said, "Elaine, I thought I was walking down a street and I came to a place with a and you will not believe what's on the other side of that door. It's amazing, a whole other world." So he did not have a full near-death experience, but he certainly had a spiritual experience that I believe was valid, that was mixed in with some of the morphine confusion. So different explanations for near-death experiences medically include hypoxia, where you can get tunnel vision from hypoxia of the nerves crossing at the optic chiasma, or temporal lobe stimulation can give feelings of expansiveness. I think the right temporal lobe is hardwired to deal with spiritual energy. I did hear a neurologist on the radio just about 5 years ago saying, "Oh, well, if you stimulate the right temporal lobe, you can get a lot of the symptoms of signs of a near-death experience, so that's all it is." And I was horrified that he was coming out with this across Canada's radio system. My thoughts are that the visual system is hardwired to deal with light waves. We perceive and process that energy, but sometimes it goes amok and you have visual hallucinations. The auditory system is hardwired to deal with sound waves and sound energy, but sometimes it goes amok and you have auditory hallucinations. And I believe that the right temporal lobe is hardwired, and if we stimulate it, we get a near-death experience because it is hardwired for us to experience spiritual energy in a valid way. I'm going to move along. DMT is sometimes people say, "Oh, well, that's what causes near-death experience," and that it's a molecule that's released by the pineal gland, but it doesn't explain everything. So that brings me to what can't be explained by biological theories. How many are aware here of the 9 lines of evidence? No? This is fabulous. It's in a book, Evidence of the Afterlife, that was written by Dr. Jeffrey Long, a radiation oncologist who's kept this huge register of near-death experiences, who wrote it with Paul Perry, who has written a number of the bestsellers about near-death experiences. And what they said is there are 9 main lines of evidence that, taken together, suggest that you can't explain it by any one biological model. And you have to take the 9 lines of evidence together. So the first one is that the level of consciousness is greater than even in everyday life. So that alone is medically inexplicable, no matter what theory is entertained. The second is that NDEers might see and hear events that are later validated by others. And how can one see an event or hear a conversation in a totally different city or a different building while unconscious? And yet you couldn't even do that if you were fully conscious. And those are called veridical events when they've been validated. The third line of evidence is that people who were blind have had near-death experiences in which they had normal or supernormal vision. Another one is that when people are monitored, have had near-death experiences under monitored general anesthesia, the anesthetist knew that they were totally under, and yet they had tremendous consciousness. Life reviews may obtain or include new information that the person wasn't even aware of prior to their near-death experience. When people encounter beings, they're always deceased, whereas if you thought it was just the subconscious producing this material, you would expect that it would include family members or friends or people that are still alive, but invariably they are deceased. And sometimes they learn of someone that has passed over when they've had this near-death experience that they didn't even know had died. What about near-death experiences of children who haven't been exposed to religious doctrine? They're strikingly similar. They're similar around the world, and the after effects are so powerful in a consistent way. So those last 3 by themselves don't prove that it's not biological. But when you take all of those 9 lines of evidence together, it's a pretty powerful statement that we can't explain it by any single biological theory. And Dr. Alexander said, "Those who assert that there's no evidence for phenomena indicative of extended consciousness believe they know the truth without needing to look at the facts." He says the thing that is the most convincing for anyone is to have an experience themselves. So, well, it may have to do with perceptual focus, it may have to do with frequencies of mind states, and it may have to do with proximity to the dying, time of dying, when the veil opens and people seem to have more spiritual experiences at that time. So the Magic Eye book is, I think, a wonderful metaphor for sweet spots and focal point. I think some of you might be aware of it, where you hold the book in front of your nose and it's all just dots, and then you pull it slowly away, and suddenly at a particular spot you see a very evolved scene, and the more you kind of look at it, the more it becomes enhanced, and then you blink again and it's all you see are dots. So there's a sweet spot. And maybe the spiritual realm is like that. But children in the dying seem to see the spiritual. And my hypothesis is that children have a more fluctuating or variable focal point, and that it hardens probably or fixates at, or gets fixed at a certain point at around 3 to 5. Why? Because we have to adapt to a physical world. So if children, or as they got older, could see spiritual and physical realms, they might want to sit on a chair that's not physically quite there. I'm exaggerating, but I think that's the point, that the focal point has to become hardened for this denser material world. And so that's why that children can see it, but they lose that ability as they get older. And then when people are dying, I think that fixation, the focal point, is a little looser. The veil, Dr. Jeff O'Driscoll, an emergency physician, speaks of the veil. He says it's like, imagine a curtain, and there's a part where it separates and newborns come in, and there's another part where the curtain separates and the dying leave. And he says that when you're working with the dying or near that person, some of the glory from the other side comes forward and shines, it is evident to the other person, and that's how he describes shared death experiences. It may also have something to do with frequency. I've been looking at some of the aspects of induced after-death communication and how they work. Rochelle Wright has one that she calls Reattachment Theory. It's a variant of Alan Botkin's work, some of you may be familiar with, but what she does is she does a form of EMDR, so she's moving her hand back and forth while she's saying statements that the person has come up with already about their grief, and then she's got people wearing a hemisync hearing thing, music. So you've got all this stimulation. I took her course for a day, and during that time, I mean, it's so overwhelming. You're trying to follow her hand and think of statements of grief and also listen to differing sounds. And I think what it does is the frontal lobe kind of just says, I give up. And it puts it in a different kind of state. I think you're blocking out the frontal lobe and accessing a different part of the brain, or maybe with different frequency. So how can we apply NDE knowledge clinically? Because 95% of people have not had them, although most have known of other people who have. I think we can use the story so powerfully. We can validate the near-death experience for near-death experiencers so that we don't misdiagnose them. We can validate other spiritual experiences, such as my drawing, the angel drawing. I think that was very helpful for that patient, just to know that I appreciated her spiritual experience in the leukemia ward, and I know that the rapport certainly increased after that. We can improve diagnostic accuracy. I had a patient who was referred to me for anxiety after stem cell transplant a year later, and I was just asked to see her because she was anxious. And I said, why are you anxious? She said, I'm having images about dying. And she thought these were premonitions that she was going to die soon, or that this negative thinking could lead to illness. About her experience, and she'd had a code called when she was in the hospital, and she said, well, I watched it actually, now that I think about it, from the foot of my bed, and she started describing the nurses that came in and her memories, and these were the worries that she was having, that she thought that she was a premonition. She was an atheist, and she couldn't explain any of these dreams, and she feared the worst. So I said, well, look, you've actually had a near-death experience during your code. And actually, it's already happened. And you've survived it. You had a close brush with death, but you survived it. So you must have survived it. Still alive for some purpose. But she had trouble integrating this because her identity was as an atheist. And just a second here. Her identity was as an atheist. And I think she was at the developmental stage of consolidating her identity. And just like teenagers try on different identities or like clothes, so do young people try to come to some sense of who they are. And she was very adamant that she was an atheist, and I don't think she was able to acknowledge the near-death experience. And she canceled another appointment, and I think she'll just take some time, and at some point more memories will emerge and she will have to integrate it. What about using near-death experience knowledge in other situations, psychotherapy situations, fear of dying? I had a young patient in her late 20s who was very afraid of dying. She was dying. And so I talked to her about near-death experiences. Have you? And she said, no. I said, well, they're the experiences of people that have come as close as you can come to dying and yet still survive. So let's see what they can tell us. And so I talked to her about it. Actually, I would like to also mention that she'd asked the nursing staff, what's it like to die? So they sent someone from palliative care who came and explained the physical aspects of all your breathing starts shifting, and she actually felt more terrified after that. And I said, well, I asked her, I said, did anybody explain the psychological aspects or spiritual aspects? No. So she was left with even more fear. So telling her about a near-death experience was essential for her, and I asked her if she knew anybody who'd already passed on, her uncle, and she and her mother talked about the uncle on the other side and how he would welcome her. Well, she died a couple of weeks later, but she died with much greater sense of peace. She and her husband watched the video Life After Life by Peter Shockey that's based on Raymond Moody's book. I had an intuition at one point that I should see an acquaintance who she was expected to live about 3 weeks. I didn't know her very well, but I just suddenly one afternoon thought, you got to go. So I'd only met her once, actually. So I drove out to see her, and I expected she'd live another few weeks, but I asked her what she felt about or what her thoughts were on dying. Well, she was Christian, but she still was pretty nervous. And I said, have you had any interesting dreams lately? And she said, well, my deceased brother has been in my dreams lately. And I said, well, he's probably waiting there to see you on the other side and to celebrate with you. And what a celebration it's about near-death experiences. And she thought that sounded very interesting. And I quoted the lyrics from Going Home, which is African spiritual that you might recognize, and about Mama's there and Papa's waiting for me too. The piece the next day, and I showed her husband how to do some therapeutic touch because he was feeling very helpless. So I thought that would help. And she fell asleep a few minutes later. And before she did, I said, well, I'm not sure who's going to go first, but if you go first, I said, you never know, I might go first in an accident, or who knows. If I do, I'll certainly welcome you on the other side. And if you do, then I hope you'll welcome me at some point. But in the meantime, I'll probably see you next Saturday. Well, I left, and 10 minutes later, I saw her husband in the parking lot, and he said she's fallen asleep. And I couldn't believe it, that the next day he phoned and said she never woke up. So, hearing about the near-death experience just was so calming for her, and thinking of meeting her brother, going home. And I think that's really what helped her relax. So we can use these stories, the stories of near-death experiences, so powerfully. I've used it with patients who've had past losses, and when they're sick, it sometimes triggers grief feelings again. people who are dying also are grieving their own anticipatory losses. And we talked earlier about, I gave the example about the woman who was afraid she wouldn't see her husband again because she was a born-again Christian and he wasn't. And that's when I said, I think we should think outside the box. But what helped me at that point was talking about near-death experiences. Have you heard of near-death experiences? No, she hadn't. I said, well, you know, there are a lot of features of near-death experience in the Bible. The being of light, Jesus says, I am the light, and what the day of judgment could be like the life review. So she was Christian, so I used the knowledge of it in terms of her own faith. Obviously, I wouldn't have definitely said that if she wasn't Christian, but that's how I approached it. And so that really helped her think outside the box about heaven and feel safer about her, feel happier or more contented that she would possibly see her husband again. I've taught near-death experiences to the relatives of patients who've died. I had one patient who hadn't thought much about it, but he thought he'd go somewhere after he died. So we talked about near-death experiences to give him some greater focus, some ideas, increased hope. Neither of us knew, but it was our last appointment. After his death, 2 weeks later, I met with his sister, and she felt so reassured to know that we'd had a conversation about near-death experiences. She watched the video that I'd shown her brother, and it created a sense of resolution for her. She knew who her brother had seen before he died, myself, but she knew she felt about his passing. I was the link to the brother. I think where we can really powerfully use these stories in emergency or an outpatient. Lara was a patient of mine who was having chronic suicidal ideation. I told her about near-death experience of Sandy, a woman in the video Life After Life, who shot herself in the chest and then had a near-death experience and survived it. And she had a choice in her near-death experience of going on and dying or coming back. But she, as she says in the video, I realized that if I went on, I would have to relive all of that pain again, starting from the beginning, right up to where I tried to commit suicide, and then go onward from there. And she said, I decided I wouldn't be saving myself any pain, and I looked at my life, and it had been full of pain, and I didn't want to go through all that again. So I told my patient this story, and the following week she came back, and I said, well, are you having any more suicidal ideation? She said, oh no, I thought about Sandy, and I sure didn't want to have to go through all my pain again, so I don't want to go through that. And that was the end of her suicidal ideation. It wasn't an idea she toyed with after that. But I've also used it with patients in the emergency that I didn't know before, and who were feeling like there was no hope in their lives, and I've asked them about their spiritual beliefs, but I've also talked to them about, do you know about near-death experiences? Have you ever heard of anybody who's had one? Well, this is what I know about them. And I tell the story of Sandy. And I don't always see the patients again who've been in Emerge, but I always hope that maybe I've just dropped a little pearl or something that they can hang on to at some point in the future. We can also use near-death experiences for patients in spirit, people who have a sense of lack of purpose in their lives, to underscore the possibility of a greater purpose in life. And I've done that with leukemia patients and others. I want to tell you about in her 80s. She was an atheist woman with a narrow life view. She'd had a history of cancer, that's why I saw her. And she had a multi-generational history of relationship difficulty. Multi-generational depression, her mother, herself, her daughter. And because of that, there were also personality issues. They were probably all borderline personalities for those of you who are familiar with that. And I said she came from a line of prickly porcupines. Well, I tried everything with her. I tried to address all the pertinent medical, psychological, social, and spiritual factors. I looked at the medical factors of cancer. I looked at mood issues. I prescribed various antidepressants, pushed them to the maximum dosage, tried a different one. But she remained very sensitive to rejection and criticism. And the slightest thing she would get really prickly with. So I focused on various issues of psychotherapy. That didn't help. I tried to kid her along at times when she would be snippy with me, and said that I still cared about her. I tried to bolster her in every way I could. I tried to suggest she go back to, try to find some social groups, or try to go back to the Unitarian Church where she had once attended. So I said, why don't you read about this book, Life After Life? Well, she took it home. She came back. She wasn't convinced. I gave her another book, Closer to the Light, about children's experiences. So she came back and she said, wow, those children weren't experiencing as a child. Maybe there's something to this. And that was the pivotal shift. It was amazing. She calmed down. She was just very different. A few months later, in her 80s, she was diagnosed with metastatic illness, but she faced her situation with peacefulness, a sense of serenity, of hope, and this was nudged along by her new knowledge of NDEs. The topic was divinely led. I'd known her for several years. There was no indication her cancer would return. And yet that made all the difference. In the last few months, she was more philosophical, and she had a greater sense of hope. So, and finally, near-death experiences, we should be using them to look at how we view mental illness and consciousness. And we heard this morning, I would say the hardware for the consciousness software, and that the brain appears to filter out information. That's not nearly as elegant as what we heard this morning. But there are implications in how we approach psychosis. I was trained in the biochemical model, and I thought that all psychotic illness was biochemical abnormality. I once heard a minister give a sermon about possession, and I was horrified because I said this poor patient with schizophrenia should not be labeled as being evil. But then I heard about George Ritchie's story, and in George Ritchie, in his near-death experience, he popped out of his body and walked down the ward, and the ward boy came right through him. And then George Ritchie went elsewhere and tried to ask somebody some directions, and that man walked through him. And then he met with, he thought, Jesus, who took him on a tour to a bar, and they watched, he watched discarnate souls trying to enter the bodies of intoxicated people. And sometimes this would happen. And he said, time to time, one of the human beings would become totally intoxicated, which caused the electrical field or aura to separate, starting at the head and going to the feet. When this would happen, one of the less dense beings without the aura would try to beat out the other similar ones getting into the human through the separated electrical field. And they were trying to enjoy the feeling of intoxication. And that inspired Dr. Ritchie to dedicate his life as a psychiatrist to treating alcoholism. But what are the implications? His account was cohesive. Was he misled? Or are the biochemical paradigms of illness overly simple? If we think that human beings can walk through discarnate souls, what kind of energies may be passing by? So this totally changed my thinking. And can happen with intoxicated people. What about psychotic people who are not in full control? most psychotic schizophrenics do not commit horrific acts, but now and then you do hear of horrendous things where people suddenly take an axe and murder a family member, and then they're horrified afterwards. Well, I thought, is there something going on with a demonic energy that is taking advantage of the psychotic state? And I certainly wouldn't have thought about that before I read Dr. Rich. This modifies our perspective of symptoms of schizophrenia. And I'm not sure with time. Okay, so I'm going to finish off at this point, but it certainly does give us pause to wonder about implications and for multiple personality disorder. So in finishing, I think we can bring awareness of NDEs to the emergency department, to acute medical care, burn units, surgical settings, palliative care, hospice settings. We should be teaching the younger generation of doctors, especially in this era of physician-assisted suicide and do not resuscitate orders and advanced directive planning. I think we need to be having professionals that are more aware, fully aware of quality. So thank you very much.